السلام عليكم. دلوقتي هنبدأ راوند تيبل على challenges and difficulties before and after cochlear implant. الفيرست ليكتشر معانا أستاذ دكتور توجان طه، أستاذ بقسم الأشعة جامعة عين شمس. اتفضلي دكتورة توجان.
بسم الله الرحمن الرحيم. هو أنا بس عايزة أقول المحاضرة بتاعتي إن شاء الله هتمشي إزاي. هي كان المفروض إن هي workshop يعني. أنا حاطة الحالات اللي كلها اشتغلتها مع حضراتكم، فهي كل الحالات ديّة our cases our patients. يمكن أنا حاطاها في شكل أسئلة، اللي هي الأسئلة اللي بتيجي في دماغي وأنا باكتب التقرير، كنوع من الinteraction يعني. هنحط الأسئلة حضراتكم هتفكّروا معايا يعني في الإجابات، وبعدين أنا هاستنى حوالي مثلًا 10 ثواني أو حاجة، وهاقول الإجابة على طول، وهاقول قُلنا الإجابة كده ليه يعني. بسم الله الرحمن الرحيم. Congenital hearing loss may not follow the known inner ear anomaly or even syndromes. Sometimes unusual combination of different anomalies make the cochlear implant a tough decision. My first case is a 3-year-old child with congenital sensory neural hearing loss sent for pre-cochlear implant evaluation. Regarding the inner ear development, check all that apply. It's a case of bilateral labyrinthine aplasia, a case of bilateral variable degrees of incomplete partitions anomalies of the cochlea, a case of right internal auditory canal aplasia. It is right labyrinthine aplasia and left IP1 anomaly of the cochlea. Think please. The correct answer, it is a case of right internal auditory canal aplasia, and it is right labyrinthine aplasia and left IP1 anomaly of the cochlea. Sentence A was wrong as the left cochlea is deformed, but it is not aplastic, and B is wrong as the right inner ear structure are absent. In the same patient, regarding the external ear, check all that apply. This is normal left ear pinna, enlarged right ear pinna, left external auditory canal is well patent and normally developed. It is not the proper modality to comment. Think please. Actually, it is not the proper modality to comment, as the external and the middle ear development is better evaluated by CT. Yet, still normal right external auditory canal and atretic left side are seen in the MRI. In the same patient, regarding the arrowed structure in the left ear sagittal plane, it is normal cochlear nerve, normal facial nerve, normal inferior vestibular nerve, or it is hypoplastic cochlear nerve. Think please. It is hypoplastic cochlear nerve. After reviewing the MRI in this child with right labyrinthine aplasia with normal external auditory canal, left IP1 anomaly with hypoplastic cochlear nerve and external auditory canal atresia. Which ear is candidate for cochlear implant? Check all that apply. Left ear is candidate for cochlear implant. Left ear is a relative contraindication for the cochlear implant. Right ear is an absolute contraindication for the implant. Left ear is an absolute contraindication for the implant. Our clinicians showed this is a tough decision with relative contraindication. Left ear is a relative contraindication for the cochlear implant with expected poor response and risk of CSF gusher. And of course, right ear is an absolute contraindication for the implant. My next case is a 10-year-old child patient with left moderately severe and right mild sensory neural hearing loss. Please check all that apply. The spine anomaly is irrelevant to the pre-implant imaging. CT shows hypoplastic right internal auditory canal. Usually contrast is not used in the pre-implant imaging protocol. Spine and CPA anomalies form the main features of a well-known syndrome. Think, please. The correct answer is usually contrast is not used in the pre-implant imaging protocol. Sentence A was wrong, as the spine imaging is not part of the pre-implant imaging protocol, but in this child, Chiari-1 malformation may explain part of the presenting symptoms. Sentence B was wrong, as abnormal widening and scalloping of the left internal auditory canal. On the contrary, the right canal is a normal one. And sentence D is wrong, as the shown anomalies form two separate syndromes that may associate. During reporting this patient, we noticed a cord-like abnormality passing around the cochlear promontory, which is the arrowed structure or abnormality. Check all that apply. It is a glomus tympanica. It's a facial nerve schwannoma arising from the tympanic segment. It is a chorda tympani schwannoma. It is a Jacobson nerve schwannoma. Think, please. Yes, it is a Jacobson nerve schwannoma, as this nerve is a branch of glossopharyngeal nerve entered the tympanic cavity via the inferior tympanic canaliculus and contribute to the tympanic plexus on the cochlear promontory. This is a case of neurofibromatosis type 1 and Chiari-1 malformation. Some studies suggest that Chiari-1 malformation should be accepted as one of the central nervous system anomalies seen in the neurofibromatosis 1. Neurofibromatosis type 1 is often associated with a wide variety of central nervous system dysplasia. However, association with Chiari-1 malformation is unusual. In this case, the left sensory neural hearing loss is explained by the vestibular schwannoma extending along the internal auditory canal. We presumed that Chiari-1 malformation is the cause of the right sensory neural hearing loss and possibly contribute in the left side symptoms. During the caudal shift of the brainstem in Chiari-1 malformation, the eighth cranial nerve is compressed over the bony edge of the porus acousticus, in addition to direct compression of the brainstem nuclei by the cerebellar tonsils. My next case is a 36-year-old female patient with bilateral sudden sensory neural hearing loss following an attack of domestic violence. MRI was done searching for a hematoma compressing the nerves or any type of nerve injury. Please check all that apply. No obvious nerve injury, however, there is cochlear concussion is noted. Pre-existing vascular anomaly is the cause of the current patient's complaint. Pre-existing congenital inner ear anomaly is the cause of the patient's complaint. By history and the current MRI images, it is a case of central cause of hearing loss. The study is unremarkable and further imaging is needed. Think, please. The correct answer is pre-existing congenital inner ear anomaly is the cause of the patient's complaint. Sentence A was wrong, as the cochlea shows normal signal and there is no intralabyrinthine hemorrhage or cochlear concussion. And B is wrong, and I will explain this later. Sentence D is wrong, as no available radiological features of central hearing loss. And E is wrong, as there is variable abnormalities in this case. This is a case of bilateral dilated endolymphatic duct and sac anomaly, or what is known enlarged vestibular aqueduct. I report this case by the enlarged vestibular aqueduct, but the clinician was not convinced with my report, so he asked additional CT, searching for an otic capsule fracture. And here is the CT with enlarged vestibular aqueduct in the sagittal plane that measures 1.3 milli. Advances in multi-detector CT resulted in further development of the diagnostic criteria, which considered the vestibular aqueduct enlarged when the midpoint or opercular widths surpass 0.9 and 1.9 millimeter respectively. Enlarged vestibular aqueduct is the most common radiologically detected abnormality in patients undergoing evaluation for sensory neural hearing loss. The typical and treated progression of this syndrome is a gradual deterioration of hearing through the childhood into adolescence and early adulthood, with a tendency to suffer sudden drop of hearing, particularly after head trauma. After reviewing the arrowed structure in the same patient, what makes this choice incorrect? Remember, we told that pre-existing vascular anomaly is the cause of the current patient's complaint, and this was wrong. Why this sentence is wrong? The arrowed structure, it is a hematoma around the cochlear promontory. The vile structure, it is a fracture line passing the facial nerve canal. This is a facial nerve schwannoma affecting the tympanic segment. There is a pre-existing vascular anomaly not related to the patient's recent symptoms. Answer, please. Actually, it is a pre-existing vascular anomaly that not related to the patient's recent symptoms. The red arrow is not a hematoma, but it is an apparent course of the internal carotid artery passing around the cochlear promontory. And the violet arrow is not a fracture line, it is a duplication of the anterior segment of the tympanic facial nerve canal. And the violet arrow in the MRI, this is not a schwannoma, it is a persistent stapedial artery as it traverses the floor of the middle cranial fossa to give rise to the middle meningeal artery. And this is an accidental discovery of apparent internal carotid artery with persistent stapedial artery in the same patient. So in this case, the subtle radiological abnormality noted in an unexpected age in this patient with no past history of hearing loss made the diagnosis challenging. The coexistent vascular anomaly added to the confusion. My next topic will be about the obstructed cochlear lumen. Patency of the cochlear lumen, normal composition of the internal fluid, and the intact blood labyrinthine barrier are essential for the normal hearing. Cochlear lumen obstruction could be mechanical or functional in form of alteration of the internal media. Imaging protocol should be tailored according to the clinical scenario. My next case is a 5-year-old child with recurrent attacks of meningitis complicated by sensory neural hearing loss, referred for pre-operative evaluation for cochlear implant. Please check all that apply. This is a normal cochlear development, patent cochlear lumen. Congenital inner ear anomaly is the cause of recurrent meningitis. The study is unremarkable. Think, please. The correct answers are normal cochlear development and patent cochlear lumen. Sentence C was wrong as there is no congenital inner ear malformation in this patient. And D is wrong because significant abnormality is seen. MRI was done for the same patient. Please check all that apply. MRI confirms patent cochlear lumen. Enhancing a cochlear lumen is a normal finding in this age group. It's a case of encephalomalacia of the brain with central hearing loss. All the above are false. Actually, all the above are false. Sentence A was wrong as obstructed cochlear lumen is obvious in the MRI with loss of the fluid signal in the T2 weighted images. Sentence B is wrong as enhancing cochlear lumen is always pathological. And sentence C is wrong as the frontal lobe encephalomalacia is not the cause of central hearing loss. And this was undiagnosed or missed anterior skull base defect with meningoceal that are the cause of recurrent meningitis, which complicated by labyrinthitis, which in this case a fibrous stage of labyrinthitis. The labyrinthitis is a major cause of hearing loss in different diseases as meningitis, ototoxic drug, autoimmune inner ear, or trauma. Labyrinthitis ossificans is the result of neglected labyrinthitis. Regardless the triggering cause of labyrinthitis, the cochlear inflammatory process follows the same pathological cascade with corresponding radiological finding. This is an acute stage in which the T2 is normal and the only sequence that shows the abnormality is a contrast enhancement because of disruption of the blood labyrinthine barrier and the presence of inflammatory material. This is a more chronic stage, but the CT is still normal, but there is loss of the fluid signal in the T2 due to the fibrosis and there is still contrast enhancement. And this is the last and chronic stage, which is the labyrinthitis ossificans, which finally the CT is abnormal, displaying the calcification or the ossification with fibrous matrix obstructed the cochlear lumen. This is another patient, 10-year-old child with recurrent meningitis and bilateral profound sensory neural hearing loss. Check all that apply. The right cochlea is fully developed, however, it has an obstructed lumen. The left cochlea has a patent lumen, however, it is malformed. There is a congenital CSF fistula that causes the recurrent meningitis. The primary cause of the sensory neural hearing loss is the recurrent meningitis. Please think with me. The correct answers are the left cochlea has a patent lumen, however, it is malformed. And there is a congenital CSF fistula that causes the recurrent meningitis. Sentence A is wrong as the middle and the apical turn of right cochlea are fused together with defective corresponding modulus and the interscalar septum. And sentence D is wrong as the primary cause of the sensory neural hearing loss is the inner ear malformation, but the recurrent meningitis accentuated the condition. This child has a right incomplete partition type 2 and left IP1 anomaly with defective left-sided lamina cerebrosa and congenital CSF fistula, predisposing this patient to the recurrent meningitis that was complicated in this case by labyrinthitis ossificans partially obstructing the right cochlear lumen. This is my last case. A 15-year-old male patient referred for MRI cysternography. The medical report sent by the clinician is shown. He told us he is 15-year, past history of head trauma long time ago. He has recurrent acute bacterial meningitis. Much brain imaging was done. Please for MR cysternography. MR cysternography was done through the different skull base regions, searching for the site of CSF leak. Please check all that apply. There is an anterior skull base defect through the cribriform plate of ethmoid. There is a central skull base CSF leak through Sternberg's canal. The CSF leak is through the tegmen tympani. No CSF leak is shown in these images, but there is another clue. Think, please. Yes, there is no CSF leak in these shown images, but there is another clue, and here is the clue. More magnified images for the left ear. This is a case of congenital CSF fistula through a defect at the level of stapes footplate, commonly associated with IP1 anomaly detected in this case. Many challenging issues in this case: a misleading history of remote head trauma and multiple previous brain images, ignored hearing loss in the history, considering it a sequel of meningitis, requested cysternography protocol rather than a dedicated cochlear implant protocol. IP1 is commonly associated with recurrent meningitis due to abnormal otic capsule that is involved in the formation of stapes footplate and the annular ligaments, resulting in congenital fistula. Another site of fistula is the defective lamina cribrosa and wide communication with internal auditory canal, which is another factor. Finally, in this short workshop, I discussed the complex causes of sensory neural hearing loss can make the cochlear implant a tough decision. A non-congenital anomaly that may present in unexpected age group, making the diagnosis less straightforward. Cochlear lumen obstruction could be either mechanical or functional. Meningitis and hearing loss have a bidirectional relationship. And thank you.
Thank you, Dr. Togan, for your informative lecture and very nice lecture and presentation. And now with our professor, Dr. Lubna Al-Faqi, to show us the cochlear surgery difficulties and challenge cases.
Good afternoon, everybody. And thank you again for the very nice cases that you presented. And here is also one that you have a role in it. Actually, I'm just exposing one case which is very peculiar for recurrent meningitis, inner ear malformation, and cochlear implantation. All of that together to answer question in difficult cases. The case was a 31 years old female patient, otherwise healthy, and developed an attack of meningitis and admitted to Fever Hospital, receiving treatment with complete recovery without any sequelae. 1 year later, she developed a second attack of meningitis, still hospitalized and received treatment, and she recovered from unconsciousness, but she had a sequelae in the form of bilateral severe to profound sensory neural hearing loss on audiological evaluation. And she was actually preparing for cochlear implantation. Of course, obviously, she is a postlingual, and she had to have a cochlear implantation. So imaging, she didn't do any imaging during the meningitis regarding the ear. As just Tugan said, they were just making brain examination for the meningitis she developed on the two occasions, but they did not investigate the temporal bone. Here is the result of the temporal bone with IP1 on the right ear and cochlear hypoplasia type 3 on the left ear. So she had bilateral inner ear malformation, which explains actually the loss of hearing due to the meningitis. And usually meningitis does not cause labyrinthitis ossificans in big abnormal cavities or inner ear malformation with lot of CSF inside. However, we passed this as normal, as only inner ear malformation, which the type said. But actually, when you look a little bit closer, it wasn't us that looked or discovered that. It was Dr. Togan, and she pointed that there is أشاور بإيه؟ بده pointer الأحمر. Okay. And here we can see the fistula. This is the vestibule, the abnormal vestibule, and there is a fistula and soft tissue shadow, actually a rounded soft tissue or cystic soft tissue shadow on the oval windows place. It wasn't clear in the previous cut. You can pass it as normal, but actually it was there. Of course, we know that Tugan takes a very good look and bigger on the machines, and she diagnosed it as a rounded stapes foot plate fistula. So actually, also we had the same thing on the MRI. MRI, you could pass it as normal abnormality IP1 here and cochlear hypoplasia in the left side. But when you enlarge it a little bit, you see a little knob over here, but it has the same hyperintensity of the CSF over there, and that points to still a stapes foot plate fistula with a cystic formation on it. So the decision for us was a little bit difficult in every way. We had to, by priority, to identify and treat the condition that causes the meningitis, as it is the life-threatening pathology that she has. Of course, we saw together the right small CSF filled mucosal pouch in continuity with the vestibule, the cystic lesion over the foot plate, right stapedial foot plate fistula was then diagnosed by the radiology that she did. To decide on the side of surgical exploration, of course, we have to prioritize the control of the fistula by exploring the right side. The last thing to take a decision, should we go for cochlear implantation in the same session, in the same ear or the opposite ear? And all that was actually counseled for the patient and her family to know that there is multiple difficulties encountered, and at the end of the day, intraoperative decision can be changed either to do only control of the leak or together with a cochlear implant. And this is how did we see it inside the operation. This is actually the cyst over the foot plate or between the two anterior and posterior crust of the superstructure of the stapes. This is the tendon, the stapedial tendon, and over here is the cystic swelling that we saw and diagnosed on imaging. And here is it again. Actually, the plan was just to pack it, better to leave the superstructure and foot plate, although there is a fistula, but if we control the fistula only without removal of the foot plate and the superstructure, it will be a better control. So we tried actually to do packing of the foot plate by muscle, by pieces of muscle. In the beginning, it went okay to compress the cystic protrusion of the CSF or of the perilymph over there. The more you do, you put a muscle to control it. It gives you a control for a few seconds. Then you find it that there is a leak from around it. The more we put fat or muscles over the fistula, it gives us more and more CSF until the CSF came out of the mastoid air cells, and we are packing more and more and still without control. It is compressed, of course, but it's not totally compressed because it's reaching the anterior part of it. So the decision was to make a subtotal petrosectomy. And that's what we did. We removed everything and we did a subtotal petrosectomy. And it was controlling a little bit the CSF leak medically by our anesthesiologist. We were able to do a round window cochleostomy to complete our operation with the cochlear implantation. The decision was made once we finished the subtotal petrosectomy. The Eustachian tube was closed to make sure that the CSF is controlled, and we were ready actually with the Medel Form 24 electrode, which has a specific cog to close the leak or to help to close the leak, and in the same time to close the external auditory canal and remove the external auditory canal to compress the CSF leak. This is the Form 24 electrode. And it was put to the end, fully inserted with the cog or the plug that controls the CSF coming or the perilymph coming through the round window. Still packing was done post-operatively, post-insertion, and we made sure that it's totally controlling the leak before we closed and pack the whole cavity. Again and again, we compressed all the points that bring perilymph into the field, and we completed the subtotal petrosectomy. So there was a dehiscence of the foot plate, which we call stapes foot plate fistula. Usually it is due to industrial layer development. The industrial layer, that means the inner side of the foot plate, and usually it occurs in inner ear malformation that causes meningitis due to this fistula, either much more common in the literature in the incomplete partition type 1, like the case that we have, and sometimes in cochlear hypoplasia also. In our case, it was unilateral, it wasn't bilateral, and also it is reported in the common cavity cases. And this is the classification in the literature of foot plate fistula. This is the normal thickness of the foot plate. Sometimes it's thinned out. This is the dehiscence or deficiency of the industrial layer. And sometimes it goes out from the high pressure of the CSF and it protrudes from a defect inside the foot plate and making a cyst like that. This was our case, and that's why we didn't want to remove the superstructure, as it helps to fix any piece of muscle to compress it. And sometimes there is no cyst, and there is also only a bony defect or a space defect of fistula over there. There is also radiological criteria of stapes superstructure fistula, 3 of them. You can see in effusion feeling the middle ear, and to know that this is a CSF, it's much more better to do it in the MRI with the hyperintensity 2 signal more than just the fluid soft tissue shadow in the CT scan, which can be a normal otitis media with effusion shadow. Soft tissue, like we saw in the CT density at the area of the oval window on the CT scan, and a cystic structure apparent on the oval window at the same area, but on MRI to prove that there is a CSF is actual pathognomonic. These are the radiological. If you are okay with it, Tugan, I guess it's that. Finally, recurrent bacterial meningitis warrants prompt investigation of the underlying cause by imaging of the anterior and lateral skull base for exact localization of the site of the CSF. Actually, it's not only in symptomatic cases, even if you diagnose it without the criteria of imaging and only the recurrent meningitis, you have to seek it for just the fistula without any soft tissue apparent in the radiology. In cases of single-sided deafness, sometimes it occurs there is a one-sided inner ear malformation, and the normal side and the other side is normal without inner ear malformation. Beware even of these cases. They are more dangerous because they will cause labyrinthitis ossificans by the meningitis in the other normal case. So maybe you will not be able to do the cochlear implantation on both sides, and the patient can be referred for a brainstem implant. It is essential to monitor the hearing of patients with meningitis, especially the one that don't have any predisposing factor, because actually it will provide a clue for the etiology, either by the discovery of the inner ear malformation or stapes foot plate superstructure. And the hearing loss may indicate the fibrosis and subsequent labyrinthitis ossificans. The surgical access depends on the priority for the patient. Of course, the priority is the complete control of CSF leak, and that's why you can reach to do a subtotal petrosectomy for control of the leak from all the medial surface of the inner ear. Sometimes even there are some fistula that can do the same over the round window membrane, and even in other inner ear malformation like IP3, but it's not very common. And of course, we have to manage the status of hearing loss, and we can do it. Packing for control is very important at the vestibule and the foot plate, and better to keep the foot plate in place. Subtotal petrosectomy is your backup operation, and of course you have to obliterate the Eustachian tube and do a blind sac closure of the external ear for safety and to prevent recurrent meningitis. So the history of meningitis and hearing loss should alert any physician, not only otolaryngologists, but all physicians dealing with fever. And actually in our hospital, the National Fever Hospital, they are aware of it for years now, even before cochlear implantation. We have to know that the source of meningitis in ear and ear malformation can be along small fistulas at the foot plate, and usually they are fatal and sometimes pneumococcal without even recovery from the patient. The chances of connection between the internal auditory canal and the cochlea through a dehiscent lamina cribrosa are there if we diagnose inner ear malformation. Radiological sign may be present in an asymptomatic patient. However, we have to deal with it, not to wait for labyrinthitis ossificans to occur. We have to make every effort to control the leakage point, and management is challenging. It's time. Of course, I just put a few minutes of the operation, but be sure that this is a lengthy operation, and you have to think it over and make very hard decision even during the surgery itself. Thank you for listening.
Thank you very much for
Microphone.
Thank you very much for this illustrated case. Can you elaborate on why you decided to keep the stakes foot plate? If we are dealing with an analogous case in case of staphylectomy, for example, if you have troublesome leak, the best solution is to remove, to do total platinectomy and packing soft tissue, not in the vestibule but on the surface.
Mhm.
Why here you prefer to do some total vitrectomy and not to remove the foot plate and pack the vestibule?
Okay. In the beginning, to keep the foot plate in place and the superstructure to help me for control of the fistula and the leak. The more I have a smaller part, the more it's easier. The more I have a bigger size, it's more
I think
difficult.
the reverse. If you have a fistula, it's better to remove the foot plate totally.
What?
And this is one indication of total platinectomy
Mhm.
these days.
Mhm.
The stabilotomy is the optional now. But if you have a problem with the leak, the best way is to remove the foot plate and do soft tissue packing.
I guess in the literature is the opposite, and till now even some papers point out if I remove all the foot plate, the control still of the vestibule leak is present. However, when we just compressed the cyst intraoperatively, although I can see its anterior part of it, the more I compress, the more there are leaks from everywhere, up to that I had a leak from the air cells, the pneumatized air cells, retrofacial. There were CSF everywhere. The more we put pack, the more I could have packed it without even cochlear implantation.
This foot plate, meaning when you compress it, there is leak from others.
From other side, from all the medial wall, from everywhere, anteriorly, in the attic, posteriorly, in the antrum, retrofacial air cells. There were perilymph everywhere. So I thought it had to be controlled by subtotal petrosectomy. I always consider it the easier choice, especially for cochlear implantation, because it will keep the cochlear implant and the electrode also in place without exposure to infection from outside. And usually when I read afterwards, most of the people they are keeping the foot plate at least, if not the superstructure also. Mhm.
Lubna, thank you very much. هنا الحقيقة very nice presentation. أنا بس I have two comments لهم علاقة بالموضوع عشان for the young generation. إنه I think إنه ميزة الاجتماعات دي إن إحنا نسبريد awareness يعني. أنا I think إنه بالظروف اللي إحنا فيها حاليا إنه الفاكسينيشن بقى more or less very well done يعني. لما يجي لك عيان عنده meningitis، أنا هتكلم الأول على recurrent meningitis. If you have a recurrent meningitis, you have to rule out ENT cause. ما تستناش لما يبقى عنده deafness وبعدين نحوله. وفي الأغلب لو عيان يعني otherwise normal healthy subject وجاله one attack of meningitis, you have to think of an ENT cause. لأنه غالبا هتلاقي عنده CSF leakage من النوز. يمكن الإير هتبقى أبعد شوية، إنما يا ريت كان يبقى معانا حد من نيورولوجي أو يبقى هو زي ما بنقول MDT meeting يبقى معانا other تخصصات عشان increase the awareness of such condition. الموضوع الثاني اللي هو مور كومن عن حاله الدكتوره لبنى، ان عيان جاله مننجايتس ولوست هيرنج وجاي لك بسيت سكان وام ار اي نورمال، وعلى ما خد موافقه التامين يعمل الكوكر امبلانت عدى بتاع 8 شهور، ويجي الجراح الدكتور علي او انا نخش نشتغل او الدكتور طبعا نخش نشتغل على the old سيت سكان and MRI وتلاقي مصيبه جوه ان عنده اوسيفيكيشن. ما نشتغلش كوكر امبلانت بعيان عنده هيستوري مونينجايتس الا بريسنت ايمجنج. انا would say الاسبوع اللي قبل العمليه لازم يكون عامل ريسنت ايمجنج عشان نتاكد ان ما عندوش اوسيفيكيشن جوه، لانه اذروايز العمليه مش هتنجح. رايي عليك ايه؟
أنا رأيي إن الموضوع it's very متشعب زي ما حضرتك بتقول. I have to think about the life-threatening condition in cases of meningitis. And even with the vaccination, this is written in the literature, sometimes this patient with vaccination does not completely prevent the infection of meningitis. Basically, in the fever hospital, they have that, but they are quite aware, but in the cases that develop meningitis and have some ear problems, especially if it is severe to profound, of course, they send them right away. But this case, specifically, she didn't get hearing loss with this inner ear malformation the first time of the meningitis. She developed it the second time, which is a little bit weird, to tell you the truth. But there is also an observation that the labyrinthitis ossificans does not occur in cavities. It seems the cavities with filler of fluid does not develop labyrinthitis ossificans. It develops only in normal cochlea. I don't know, this is an observation. I didn't read or find any explanation for it, but usually it happens. We have a couple of cases like that have only developed labyrinthitis ossificans in the normal cochlea and not in the abnormal one.
Same experience with recent this IB1 who developed meningitis, but
the abnormal cochlea it doesn't develop labyrinthitis ossificans. Yes.
So if you have spike of a completely you consider absolute contraindication. Some people.
It is absolute contraindication.
Some people think that the care will do a drop or.
No. I'm convinced that to do a surgery in labyrinthitis ossificans, the surgeon is responsible to be sure ahead of the operation with a recent and good radiology, and better if you have Tugan with you also, okay, to decide, are you capable as a surgeon with your experience, with your all set, can you do it? In over 90% of the case, if we can go a little bit more even than 90%, I will go for it. If I have it, if I say I might do it 60, 70%, I will not go, and I'll explain. To abort a CI should be mentally done more than actually in the and this means you are more mature and you know your limits. My limits is that. Yes, I aborted a couple of times, and this led me to be much more sensible and respect my limitation and respect the limitations of the pathology that I cannot stop on.
يعني دي حاجه مهمه قوي، ممكن يكون مفيش ناس كتير عارفه عنها، بس في حاجه اسمها فاست تراك في التامين الصحي. لو حد عنده meningitis we get the patient through الحاجات دي كلها بسرعه بحيث ان هو ما يبقاش فيه مشاكل دي.
هي المشكله يا دكتوره وفاء This is the innovation, ya Dr. Ali. Egyptian innovation. But the problem,
They brought the medical report, but their report didn't include any clue about meningitis. But someone told him go to this.
but the main problem, this is a unique innovation, but the main problem that the patients, even if they hear it from their clinician to go to a fast track, not all patients are that exact. A lot of patients, they say it does make a difference, couple of months, they do not understand. But some parents are very tenacious and they bring that these are the ones that pass through the fast track. Usually. Thank you.
Thank you, our professor, Dr. Lubna Al-Fiqi, for these very difficult and challenging cases and very nice presentation. And now we discussed the problem of congenital malformation and the challenges in the implant or not implant. And some doctors try to implant in a congenital malformed cochlea, and some other doctor refuse because of the result after that. So Dr. Hisham Taha, the professor of geology, will tell us the challenges, and they will do a cochlear implant versus auditory brain stem implant in congenital inner ear malformation. تفضل دكتور هشام.
Good evening. It's a pleasure for me to be with you today. Special thanks to Professor Dr. Lubna Al-Fiqi and Professor Dr. Tahani for their invitation. We all know that congenital inner ear disease is a very challenging condition. And it's very important to take decision whether to implant these children or not. I'm going to discuss very briefly, congenital inner ear disease, and then I'm going to discuss some cases that were done. Congenital ear malformations are heterogeneous group of congenital lesions resulting from the malformations of the vestibulocochlear structure. There are either membranous labyrinth malformations or bony labyrinth malformations. According to Sinoglu 2017, there are, this is the classification, Meckel's deformity. There is complete absence of cochlear and vestibular structures, and this is this is an absolute contraindication for cochlear implantation. These patients should be implanted by auditory brainstem devices. Also, a complete cochlear aplasia. This is another absolute contraindication for cochlear implantation, and ABI is indicated. Finally, rudimentary otocyst. There is incomplete representation of the otic capsule, and this is also a complete contraindication for CI, and ABI is indicated. The other malformations, we have to take decision either to proceed for CI or for ABI according to different criteria. For example, cochlear hypoplasia, incomplete partitions type 1, 2, 3, and common cavity, enlarged vestibular aqueduct, cochlear aperture abnormalities, and cochlear nerve abnormalities. For cochlear nerve abnormalities, if there is complete aplasia, this is also complete contraindication for CI. If there is hypoplasia, there is controversy whether to do CI or ABI, and decision making is very important in these patients. So طبعا دكتوره توجان معانا، واحنا اشتغلنا معاها في حالات كتير، وطبعا الديسيجنز بتبقى very difficult. بس احنا طبعا اول حاجه بتبقى الراديولوجي. لما بنعمل بعد الراديولوجيكال ايفالويشن we have to shift for electric ABR, which may be done preoperatively or intraoperatively in order to determine whether it is possible for these children to be implanted by cochlear implantation or not. Okay. Also, there is auditory nerve test system. This is a new protocol in which a test electrode is inserted in cases of aplasia or hypoplasia of the cochlear nerve. If the cochlear nerve is still functioning, CI is the option of choice. If no auditory nerve response is present, ABI is of choice. So this device is inserted, and after that, this electric ABR is tested. If waves are generated on site and while the child is on table, the CI is performed. If not, the child is shifted for auditory brainstem implantation. هتكلم very briefly على ABI. طبعا auditory brainstem implant is a neuroprosthetic device that provides hearing sensation to patients who are ineligible for cochlear implantation due to anatomical or medical constraints. The principle is the ABI bypasses the cochlear nerve to electrically stimulate the second order nucleus in the cochlear nucleus using multi-channel array. The components is like classical cochlear implantation, the external ear level device and internal implant. The external processor is like similar to the external processor of the cochlear implant. There is no difference at all. The difference here is in the internal system, which includes a receiver that is fixed against the skull and above the craniotomy, and multi-channel electrode array, which is placed through the lateral recess of the fourth ventricle, and a ground electrode used for telemetry measures. The mechanism of stimulation, that sound is picked by the microphone and the electric impulses are passed to the speech processor. The sound signal is then undergoes frequency analysis. They are converted to electric signals which are communicated to a conductive coil. This is the picture. Here is the speech processor, which is typical like that of the CI. And after the sound is processed, it is transmitted to the cochlear nucleus via the electrode. The indication of ABI in children are either major cochlear and vestibulocochlear nerve malformation, meningitis with complete ossification, as Dr. Lubna was discussing now, or incomplete ossification with failure of partial electrode insertion, and bilateral fracture of the temporal bone. I'm going to present two cases. This is the first case. This was a child presented with no response even to loud sounds. ABR was done with no response at all. Then we performed the aided response, and as we can all see, there is very, very poor aided response. Radiological studies was done and revealed bilateral cochlear aplasia and vestibulocochlear nerve, bilateral cochlear aplasia, absent cochlear nerves, and cystic dysplasia of the vestibule and the semicircular canals. This child was implanted. This radiological evaluation was done at the age of 1 year. Unfortunately, he was not implanted with ABI except when he was around 4.5 years old. Okay, this is another child, 5 years old child, which presented with delayed speech and language development. This is the last audiogram. The left ear showing severe to profound sensory neural hearing loss with unsatisfactory aided response. The left ear also there is severe hearing loss, and the aided response was borderline. It was borderline, but the child has very, very poor speech discrimination and significant delay in speech and language. Radiology here, this was done by Professor Tugan, but the picture is not so good here. But this child has cochlear aplasia on the right side and IP1 in the left ear. So we performed the following. We performed ANTS intraoperative, and there was no response totally in the right ear, and the left ear there was good response, and this child was implanted with cochlear implant device. The limitations of ABI is there is very unpredictable audiological outcomes. It's very expensive, and there are operative and post-operative complications such as meningitis, meningocele, and device migration. Programming the first map must be conducted in the ICU, guided by electric ABR. My current experience, about 10 patients who were performed ABI, 8 were implanted, and 2 children had failed device insertion. Most of the child has good sound detection within normal aided response, but there is limited speech and language development except in only 2 of these 8 implanted children. This is a comparison with low verbal ESP. The first is a group of children with cochlear implantation without any inner ear congenital malformations. The second, here you can see there is a significant difference. There are children with inner ear congenital malformations who were implanted, and the third group is the ABI group. We can see the significant difference between the 3 groups. ده على حاجة؟ Most patients implanted with ABI, this is nearly the speech and language they acquire, but it's better than to be totally deaf and without any language. I'm going to also present after this the other child was implanted while she was 3 years old.
السلام عليكم ورحمة الله
And she's now
وبركاته.
12 years old.
عاملة ايه يا رميسة؟
الحمد لله.
اسمك ايه؟
رميسة وليد أحمد السيد.
عندك كم سنة؟
13 سنة.
سنة كام؟
ولا أدد.
عندك اخوات؟
يوسف مالك.
يوسف عنده كم سنة؟
16 سنة.
ومالك؟
7 سنين.
حافظة قرآن؟ طب قولي كده سورة الفاتحة.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين هدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين آمين.
شكرا يا رميسة.
العفو.
This is the best child. This is the as regard to speech and language. Okay. Presentation, please. لا كانت بريلينجوال. بريلينجوال بس كانت اكسلنت ليب ريدر قبل العمليه. طيب compared to cochlear implantation, children with ABI showed much slower improvement as regard to sound detection, variable speech perception, limited speech and language development in most children. Conclusion: during the preoperative counseling, the child's parents must be informed that the results are uncertain. The earlier the detection and therefore intervention, the better is the outcome. And thank you very much. Ten years ago, nearly. So this is a 10-year process. Yeah. 1 year nearly. 1 year? Yeah. Post implantation. No, the device migration, there's failure. The device was migrated and extruded, so it was a failure. Yeah. Welcome. تفضل دكتور. ده في حاله الانس. هو قبل، لا هو الاذر الترناتيف هيبقى الكتريك اي بي ار، يعني الكتريك اي بي ار ممكن يتعمل برضه انترا اوبريتيف، ممكن يتعمل انترا اوبريتيف بس الانس بيبقى اسهل اعتقد، يعني الريزلتس، يعني احنا عملنا حاله او 2 انس، طبعا الموضوع لسه مش يعني لا مش واضح، بس هو بيدينا كلو ان الطفل ده ممكن يستجيب ولا لا بعد الانس. لان من غير كده انا هعتمد على الراديولوجي بس. طبعا الراديولوجي ممكن يبقى النيرف يعني هايبوبلاستيك مثلا، بس انا مش قادر اخد قرار اذا كنت الطفل ده هيستفيد من السي اي ولا لا، هضطر افتح ويعني واحط امبلانت وبعد كده تو فولو ذا تشايلد اب. ممكن الطفل ما يبقاش فيه ريسبونس، فاضطر ان انا مثلا اعمل اي بي اي في الناحيه الثانيه، فطبعا بتوفر فلوس وبتوفر مجهود يعني. بروموتيف ستيميوليشن ده في الادلتس مينلي، لان هيبقى فيه فريكونسي وانتنسيتي ماتشنج، فغالبا الاطفال مش هيستجيبوا للكلام ده. وكان فعلا احنا كنا بنعمله في عين شمس التخصص، انا فاكر زمان يعني من اكتر من 25 سنه او اكتر كمان. كان بيتعمل برومونتري تيست، يعني من ضمن البروتوكول كل طفل بيخش يعمل سي اي ادلت يعني كان لازم يعمل برومونتري تيست. بس ما اعرفش ايه المشكله، جهاز عندنا تقريبا، جهاز في المستشفى موجود بس ما حدش بيشتغل بيه.
موجود sometimes you have to do it because you don't have electrical on this. So in my case with shrapnel and the so we couldn't do MRE, so I had to depend on the commercial test to check for the integrity.
هو كان زمان يعني من ضمن البري اوبريتيف بروتوكول عندنا في عين شمس، وحضرتك تفتكر دكتور علي ان كان لازم يعني العيان يخش، نزلت مع حضرتك كذا مره في ادلتس وعملنا برومونتري تيست، بس دلوقتي ما يعني very question. هو تقريبا هو زيه زي الكوكلر امبلانتيشن، يعني لو عدينا لا لا هو النيورو سيرجن اللي المفروض بيخش بيحط الديفايس يعني على الفورث فنتريكل قصاد الكوكلر نيوكليس على طول. بس هو السن لو الطفل اكتر من 6 سنين طبعا هو طفل لو اصلا 6 سنين يعني ممكن يستفيد من السي اي او لا لو بريلينجوال. لكن اي بي اي طبعا الموضوع بيبقى صعب لان طبعا احنا يعني الموضوع طبعا هو يعني بعيد جدا عن الفيرست اوردر نيورون، وبالتالي الاستفاده من الكوكلر امبلانتيشن اعلى كتير من الاي بي اي. فانا ما اقدرش ادخل طفل مثلا عنده 8 سنين وما فيش ريسبونس خالص واعمل له اي بي اي، مش هيستفيد. لا كلهم قبل 6 سنين. يعني كل الاطفال اللي اتزرعوا كانوا قبل سن 6 سنين، مفيش حد كان اكبر من كده.
قبل 6 بس كمان يعني earlier يعني قبل 3 مثلا.
لا مش قبل 3. لا بص السيكونس بتاعت الاي اي بتختلف تماما. يعني العيان ده غالبا بيروح للتامين وغالبا بيترفض من التامين الصحي ككوكلر امبلانتيشن، وبعد كده بيبتدي يلف عبال ما يعمل اي بي اي. بيبقى السن حوالي من 4 ل 5، مش قبل كده خالص. يعني نو واي انه يبقى قبل كده حاليا يعني. لا التامين ما بيدفعش. لا.
ومع ذلك الاوتكمز بتاعهم برضو comparable to the cochlear implant ما هواش.
لا طبعا لا not to be compared. بس طبعا احسن من ما فيش، احسن ما الطفل يبقى يعني توتالي لف ويبقى ما فيش ريسبونس خالص يعني.
شكرا.
روح امريكا حاجه اسمها الديف كوميونتي في امريكا دي جروب كبيره جدا. they are against cochlear implantation وفي ترند عالمي against الحكايه دي. فبس يعني عايزين نقول ان الناس اللي ما بتسمعش they can live quite normal life.
شكرا جدا دكتور هشام على المحاضرة الجميلة ديت. الحقيقة احنا من ساعة المحاضرة ما بدأت الراوند تيبل واحنا عمالين نتكلم على difficulties، طريق طويل، مشاكل، تشالنجز. احنا ما خلصناش كل ده، احنا لسه بعد العملية بنبدأ تشالنجز جديدة خالص. كل اللي عدى difficulties كتيرة ومشوار طويل، واللي جاي ممكن يبقى أصعب بكتير. احنا عايزين نشوف بقى الصعوبات ده والزرع اللي احنا زرعناه طرح ونتج عنه نتيجة كويسة ولا لأ. هتكلمنا أستاذة الدكتورة نيرفانا حافظ، أستاذة التخاطب في قسم أنف والأذن ورئيس القسم، وإن شاء الله عن navigating complex cases وال maximizing outcomes. اتفضلي يا فندم.
Good afternoon. First of all, I'd like to thank Professor Dr. Lubna Al-Fou'i for inviting me to this valuable roundtable. And I'd like to thank Dr. Dina Min'im because she is the one who collected the patients for me to present it today. The primary goal for any CI user is to have an open set auditory-only speech understanding in an everyday listening environment. There are many CI users who can speak while they are using telephone, and this is of course a big achievement. On the other hand, some other patients show difficulties and they have hardly little improvement in the speech reading abilities. So we have the extremes of the outcome. So the phoneticians try to put a predictors for success of the CI patients. First was the age at the time of implantation. And of course, we all know that the earlier the better. And at the age of the onset of the deafness, age at fitting of the hearing aid, duration of deafness at time of implantation, preoperative residual hearing, the mode of communication, either total communication or oral communication, and of course, family educational level. We have other factors like environmental factors, encouraging exposure to various sounds in a natural setting, and using a spoken language frequently to provide opportunities for the CI users to hear different conversations. And of course, the family and peer support is very important factor. Then we put key factors in maximizing the CI, language outcome. How to improve the language outcome in CI users? First, by early intervention, and we all know that the sooner the child receives the cochlear implant, the better the language outcome. And of course, the time of implantation that should be before the age of 2 to 3 years. This is as well as consistent use of the CI during the living daily activities. In addition to other factors like auditory verbal therapy, and the therapy should be continuous for at least 2 years. يعني مش بعد شهرين أو 3 نقول للمريض مثلا يجي يقول أنا ما تحسنتش. لا، ده لازم should be consistent and consistent for long time. And other softwares may help the language and speech therapy like Takallam and the Karawan. They are softwares that enhances the speech perception of the CI users, as well as the parent involvement as an active participant in the therapy sessions of those children, and of course the tailored or customized therapy plan. And here comes the role of the phoniatician. The phoniatrician should give regular sessions with experienced, of course, phoniatrician with the auditory training as well as language production. Then the auditory training is very crucial and very important to use the CI. It's not enough to use the language stimulation only. It should be language, I mean speech reading, as well as auditory training. And we have to focus in the auditory training on a special hierarchy started by the sound awareness, discrimination, identification, recognition, and then comprehension. And then, despite the good phoniatrician, the good language stimulation, auditory and language stimulation, however, some patients unable to reach certain level. So we put different factors to contribute to poor language development. What are these factors? First, maybe he was a late implantation. Maybe there is a preoperative unaided time. There was a duration of hearing loss was long before implantation. Maybe limited auditory input before implantation. Another factors like poor family and socioeconomic factors like parental involvement and access to resources. It was hard. Lack of access to consistent rehabilitation programs because of their far residence. And factors in the post-implant therapy like poor quality and inconsistent auditory verbal training and variability in the speech perception outcome. Other very important factors like individual differences in the brain plasticity, and of course the cognitive ability, as well as the presence of comorbid problems مثلا like autism. Then we put a monitoring measures to see the progress or to measure the progress of language and the adjusting strategies like regular assessment of language production and understanding to identify the areas of improvement of that child using formal and informal measures. And we sometimes we go to the supplementary tools like FM system that may help to improve the language understanding, especially in the noise environment. Some other adjustments or advanced strategies that was used with the older CI users like advanced auditory training, especially the complex auditory tasks, minimal pair tasks, and the speech clarity and prosody training, because sometimes most part of them unable to give us the normal prosody. So we sometimes consist that we have to work on the rhythm, tone, expression for the natural sound speeching or natural prosody. We are going to represent some clinical cases. This case, Hasna, who had 16 years and 6 months age. She has an average IQ. She was started sessions at the Mertash Hospital 8 months ago, and she was implanted when she was 5 years and 9 months. She was a perilingual hearing loss with excellent lip reading ability, and then we are going to hear her.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين آمين.
The language before therapy was short sentence, and then after therapy, she was improved, of course, and she is able to tell a story. Her syntax is already improved. However, there is still affected higher order processing like synonyms and antonyms, and the speech show good intelligibility with improvement of phonological errors like devoicing and consonant imprecision, but the speech still show mild hypernasality, improper stresses, and monotone prosody. So, and the auditory training level of her shows that she has a level of comprehension in an open set with much difficulty in speech discrimination in noisy background. She can identify long sentences differing in stress words. She can hardly discriminate between minimal pairs. And she has poor auditory memory, word finding difficulty, and in addition, she has some psychiatric problem that she is unsatisfied because she is unable to indulge in social talks in the background noise. And this is her audiological assessment. I hope it is clear here. So what are her challenges and solution? Her language still need more improvement in the narrative and pragmatic skills, and she still has deficient higher order learning processing. So we have to train this. She needs still training on memory and auditory training to discriminate between words differing in length minimal pairs, identification training between sentences to differ in stress words, and comprehension skills in open set subjects. The second case is Nidal. He has 8 years, 9 months. His IQ is 86, يعني average. Start of sessions in Bangladesh 4 months ago. Date of implantation when he was 4 years and 6 months. He is a prelingual state and fair to good lip reading ability. Language before therapy was 2-word sentence, and then after therapy, the length of the sentence improved to be 3 to 4-word sentence, يعني long sentence with improvement of syntax and size of active vocabulary, but speech still has phonological errors affecting his intelligibility to the great extent in the form of cluster reduction, assimilation, substitution, final consonant, and weak syllable deletion. His auditory level, he can identify up to 4-word sentence. He can discriminate between some minimal pairs of different consonant and vowels. He is at the level of comprehension in a closed set with poor auditory memory span. And this is his audiological representation or the audiogram. His current challenges, that syntax is affected, so we have to train the syntax items. We should work on the speech intelligibility to be improved. We have to work on memory to improve the auditory memory span, and the auditory training should be directed to discrimination, training between words differing in length, minimal pairs differing in final consonant, identification of long sentences, and comprehension in an open set. The last case, Ahmed. He has 20 years, 3 months. His IQ is average. Started session 2 years ago, and the date of implantation was 10 years ago. He has fair lip reading ability, irregular attendance of the session, and his speech is very unintelligible.
multi tarata araba kapta seta demina seta antara.
His language before therapy, 2-word sentence, and after therapy, not too much improvement, just improve in the length of the sentence. It's 3 to 4-word sentence. His syntax improved, limited improvement, but still affected in verb tense, pronouns. He is unable to engage in conversation or tell a story. His speech has marked phonological errors, hypernasality with no improvement in phonology, and all these items are affected: improper stresses, consonant imprecision, glottal articulation, devoicing, defects in the stops, and interdental sigmatism, final consonant deletion, and vowel distortion. Yani even he has all the phonological errors that we know. Auditory level, he can discriminate just single words, and he can identify 2 to 3 word sentence from a closed set picture. And this is his audiogram. Challenges is to increase the sentence length, to use pronouns and all other syntax items, to training for higher semantic groups as still deficit, and storytelling. Speech, to improve speech intelligibility using the syllable segmentation and auditory component for words, and discrimination between voiceless sounds. In the auditory level, we are working on the simple questions, training to discriminate between words in voice versus voiceless, to discriminate between words in place and manner of articulation, identification training between sentences in closed and open set, and the recognition training 3 to 4 words in closed set. He needs a very intensive work. Our take-home message that collaboration, we have to work as a teamwork, of course, and collaboration between phoniatricians, audiologists, and families is crucial to reach our ultimate success. And maximizing speech outcome with CI takes time actually and consistent effort, but with right strategies, significant progress is inshallah achievable. Thank you so much.
Thank you, Professor Dr. Nirvana, for this nice lecture.